The clinical trial of glofitamab and rice investigated the addition of the bispecific antibody glofitamab, which are target CD20 and CD3, which is new immunotherapy, in the addition with a standard salvage chemotherapy called rice, which is rituximab, and 3 different chemotherapy regimens. And it was aimed at investigating the use of this regimen in second-line therapy for patients with diffuse large B-cell lymphoma who are potentially eligible to undergo an autologous transplant or a CAR T-cell therapy. The standard therapy for salvage of patients who are going to a stem cell transplant, with the addition of a bispecific antibody, which is a new immunotherapy. This is a phase 1 clinical trial aimed at, a phase 1b clinical trial evaluating the addition of the 2 drugs. And it included 43 patients. Patients were treated with obinutuzumab first day, as well as they started ICE chemotherapy on the first day. They received it through the first 3 days of treatment. And then they started a dose ramp up on cycle 1, day 8 of glofitamab, then on day 15 of glofitamab, and subsequently started on the second cycle with ICE and rituximab, receiving glofitamab on day 8 of each cycle. And they received up to 3 cycles of treatment. And after completing the 3 cycles, patients in complete remission could go to an autologous transplant or CAR T-cell therapy. This is a single-arm, non-randomized study. Well, the study enrolled 43 patients. The evaluable patients were 42. The patients were relatively high-risk patients, who were older than 65 years of age. 30% of the patients were primary refractory. 30% of the patients had relapsed within 12 months of initial treatment, and 72% had a relapse that was later than 72 months. The majority of patients had diffuse large B-cell lymphoma, but there was a percentage of patients, about 12%, that had double-hit lymphoma. The overall response rate, which is the primary endpoint, was 83%, with 66.7% of patients achieving a complete response, which is a very active regimen for relapsed diffuse large B in comparison with standard chemoimmunotherapy. The rates of response were comparable among disease groups, particular or risk disease groups, including patients who had early or late relapse, with all patients having responses on the 75 to 80% rate for overall response rate. In terms of safety, the rates of high-grade cytokine release syndrome, which is a complication that is frequently seen with patients receiving bispecific antibodies, was very low. No patients had grade 3, 4 cytokine release syndrome. We did see hematologic toxicity with about 50% of patients having thrombocytopenia, and a similar number of patients having grade 3, 4 anemia, as well as about 30% of patients having grade 3, 4 neutropenia. There were no grade 5 fatal events, and the rate of discontinuation secondary to adverse events was very low. The rate of cytokine release syndrome, again, was very low, with only grade 1 and 2 events, and most of them were on cycle day 1 and day 8. There were a couple of infections, but those were in 2 patients so that accounted for about 4.8% serious infections. So the fixed duration treatment of 2 to 3 cycles of treatment with glofitamab and rituximab and ICE chemotherapy, with a very high response rate and very high complete response rate, with a relatively manageable adverse event profile. The study is very significant in the sense that most of the chemotherapy that we have used for salvage or second-line therapy of a diffuse large B-cell lymphoma has not been very active over the last decade to 2 decades, with response rates that achieve 40% remission on the best-case scenario. Usually it's a little bit low, the addition of glofitamab to this standard immunotherapy achieved very high response rates and allowed patients to proceed to salvage treatments without autologous consolidation or CAR T cells. The fact that it was well tolerated suggests that the rate of toxicity or the additional toxicity from the addition of the bispecific is low, which is encouraging. And I think it really helps to suggest that we can achieve better disease control before we consolidate with an autologous transplant. So it's certainly an improvement on what we've had before.